Hi, everybody. My name is Andrea Gold. I'm one of the board members of NEABPD and a clinical psychologist. I am super excited to introduce our next speaker, Dr. Sara Masland, whose work is totally on brand with the theme of this conference. In fact, she's the lead author of a recent paper titled Destigmatizing BPD. So it's our theme here, a call to action for psychological science. Dr. Masland is a clinical psychologist and associate professor at Pomona College, and she's a trainer for an empirically supported treatment for BPD called Good Psychiatric Management, or GPM. Her work addresses the ways that stigma gets in the way and creates barriers for care, people with personality disorders, including both borderline and narcissistic personality disorder. So I'm excited to learn from Dr. Masland together with all of you on the power of knowledge as she shares her work harnessing education to destigmatize BPD and empower patients. And I predict that all of us will walk away feeling empowered by her talk. So please join me in welcoming Dr. Sara Masland.
Thank you. I'm really excited to be here today. I have long admired the work of NEABPD, and I feel really honored to be able to speak with you all. I am especially excited to be speaking with you about stigma, as this has become one of my main research areas, I would say, in the past 5 years or so. So recently, as Dr. Gold mentioned, I wrote this paper with some really wonderful collaborators. We actually all met on Twitter or X. We wrote this paper on how research in clinical psychology might actually perpetuate harm in some important ways. And we ended with guidelines and recommendations for how research might be used to destigmatize BPD rather than further entrenching stigmatizing ideas. I originally planned to talk about this work. However, I did some thinking about how this is the National Education Alliance for BPD and how important education is in this area in a way that's broader than this recent paper. I bring this up not as a shameless self-plug, maybe it's part of that too, but also because I hope that I have the chance to talk with all of you if you have interest in this paper later on. Education is also near and dear to my heart. I'm a professor at a small liberal arts college where education and teaching is paramount. I think about pedagogy every day, and when I teach about clinical psychology and psychopathology, I am always thinking about education as a tool for destigmatization. In my course on psychological disorders, we often have a final project on destigmatizing efforts where actually students have to design a project to destigmatize some aspect of mental health, and then they actually need to go out in their community and do their project. It's not enough just to plan it, but they go out and they do something about it. I also was formerly a board member for Emotions Matter, where I worked with the education and advocacy subcommittees and found that work quite meaningful. I also thought about my own journey here and how important educational settings have been for forming my ideas about BPD. The BPD stigma that I've encountered has been both subtle and overt. These are some of the places that I learned to be a psychologist. So first, as an undergraduate, I learned nothing about BPD, despite taking every clinical psychology class available to me at a top 10 liberal arts college in the United States. And I find that unacceptable. I would argue that avoidance of the topic, right, is a product and perpetuator of stigma. Then when I worked as a research assistant before graduate school, I met postdoctoral fellows who told me that BPD was scary and untreatable. Mind you, at this point, I still didn't really know what BPD was. So I only had their word to understand this. Or at least I didn't think I knew what BPD was, although I later learned that I had had experiences with it, but didn't know that. This certainly didn't motivate me to learn more. And then in graduate school, there was little curriculum devoted to BPD, but I at least had an advisor who had a specialty in this area and introduced me to a really compassionate understanding of BPD. And for that, I will be forever grateful. My very first clinical training brought me face to face with significant misunderstanding, including the belief that BPD is not a valid disorder and is in all cases is caused by significant trauma. Not to say that it isn't sometimes, right? But not always, as I was taught. I started to learn what BPD truly is when I went to McLean Hospital with an interest in self-harm. And it was there that I learned a great deal from people who truly care about the people who are most affected by the disorder. In short, I have been taught through my educational experiences to view BPD in a stigmatized way. At the same time, I've had amazing educational experiences through which I learned from compassionate and forward-thinking people about BPD. The stark contrast between these experiences has always stood out to me and is part of what has driven my quest to understand BPD stigma. And so I want to talk today about the role of education in destigmatizing BPD. So this is my outline. This talk might feel at first like a bit of a hodgepodge or a collection of topics. My students, I have one former student in the audience, can tell you that sometimes my mind is a little bit tangential. However, I will draw a thread of connection for you all at the end, so do bear with me on that. I will help you see how this is all connected. I'll first talk about some basic research that shows that education is a key pillar of destigmatization. I'll then tell you about how educating clinicians is key to attenuating the stigma and negative attitudes that they hold about BPD. Before I turn to the state of personality disorders training in PhD and PsyD programs with some brand new data from my lab, I'll then change course a little bit to talk about psychoeducation and self-stigma before I provide that thread that weaves everything together with a summary and a view of how we might move forward. So first, education as a pillar of destigmatizing work. So social psychologists have studied stigma much longer than clinical psychologists have, including Patrick Corrigan and other colleagues, and they've argued that destigmatizing work generally falls into three types of key approaches. First, there's contact interventions. Oh, something happened there. I apologize. Contact interventions are often considered the most effective and the strongest and longest lasting. These include interacting in meaningful ways with people who have lived experience of mental illness. And I know that many of you in this room have shared your personal stories. And when you do, you are doing this important work. However, this type of intervention is not always feasible. And I would argue that it's not always just or fair to expect the people who are stigmatized or minoritized to do all the work of destigmatizing. Protest is another pillar of destigmatizing efforts. And protest includes things like boycott, active protest, or rallying, and other forms of active advocacy. Protest is important for sending things like moral messages, and sometimes economic messages in the case of boycott, but it can have rebound effects whereby people react to the protest itself by doubling down on their stigmatizing ideas. One example of protest action is from the 1990s, actually, when Paramount Pictures produced this movie called Crazy People. And the title of the movie itself was offensive, as was the original poster, which showed a picture of a cracked egg with hands and arms and the caption, "Warning, crazy people are coming." After pointed discussions with advocacy groups, Paramount Pictures actually changed their marketing strategies for this movie and released a new poster with a new slogan that said, "You wanna laugh tonight." So protest was effective in that example. Finally, there's education, okay, which across the board typically predicts improvements in stigma, more so for adolescents than adults, which suggests that reaching people when their beliefs are more malleable may be important. The limitation of education is often that the impact could be relatively small, and it's sometimes short-lasting. And in many cases, it might reach those who are already the most interested, rather than the people who are the least interested and who may actually have some of the most stigmatizing views. I recently became interested in whether education itself can have rebound effects, much like protest efforts. So in other words, when we educate about mental illness, might we accidentally entrench stigma? And specifically, I was thinking about cases when we, for example, teach about BPD by presenting the myths and the facts. And oftentimes we'll say something like, many people believe this negative thing about BPD, but the truth is this. And I was worried that in subtle ways, when we invoke that stigma by actually stating what the myth is, in the service of dispelling the myth, that we might actually see an ironic kind of effect whereby we further entrench that belief. So what we did in my lab is we recruited undergraduate students with no prior psychology coursework, and they learned about schizophrenia. So this was a study of schizophrenia, but I think it definitely is applicable to BPD, and we have an ongoing project that brings this work in that direction. And they learned about schizophrenia in one of two conditions. So that myth condition, where they might learn something like, many people believe that people with schizophrenia are violent or dangerous. But the truth is, and then the statistics are presented. Or they learned about schizophrenia in a no myth condition, where they just got the true information about schizophrenia without the presentation of the myth. We then had them rate their attitudes about a person with schizophrenia before completing a knowledge quiz, just to ensure that they had actually learned the information we were teaching them about schizophrenia. And what we found is encouraging. Something is cut off here as well, but the green bar is the no myth condition. This is good news for educational efforts. We found no difference in stigma between the two conditions, meaning that invoking the myth before dispelling it did not ironically increase stigma. The effect size here is very small, which is a good thing in this case. And although the study covered schizophrenia, as I said, we are generalizing this to BPD currently in an ongoing study. Next, and remember, I warned you this would be a little bit of a hodgepodge, but I'll draw the connection. Okay. I want to cover the topic of diagnostic labels, as that is one of the themes of this conference, as I understand it. And I'd like to argue that diagnostic labels in some cases might be themselves a part of education and are key actually for education. Certainly, I'll talk to you about psychoeducation, and to have proper psychoeducation, you have to have the right diagnosis. And I'll talk about that a little bit later. Here, however, I'm going to tell you about a study that we did in the lab that examined how the BPD diagnostic label informed the average participant's view of behaviors that are common to BPD. So we did two studies. I'm going to show you the conditions in the first study here. So in this study, we randomized people to one of three conditions. In the first condition, they read about Anna, a 27-year-old woman with borderline personality disorder. This is a person-first condition where she's presented as a person with a disorder. Then we had a condition where she was presented as a borderline woman. So it's actually used as an adjective here or sometimes as a noun, right? So we often hear different communities have different preferences for different types of labels. And the original intent of this study was actually to understand how those different types of labels had an impact. Or they learned about Anna in this way without a label. Anna is a 27-year-old woman. There's no diagnostic label in this condition. They then read a vignette that varied only by these labels. So they read about Anna and some behaviors that are consistent with BPD. And they read about her as a borderline woman, as a woman with borderline personality disorder, or just as a woman with no diagnostic label at all. And I mentioned that the original intent of this study was to actually study the difference between these labels, primarily the person first label and this noun or adjective label in the middle. But our findings are actually interesting in a different way. So we actually had two studies, and there's a lot to walk through here. So I'll walk you through the primary finding. But in both studies, what we found is rather than there being really important differences between those two types of labels, in both cases, when the behavior was unlabeled, when the BPD diagnosis was not provided in any way, that led to the most stigmatizing attitudes about Anna. And I'm not naive. I know there's a lot that goes into labeling. But this is just one element to consider. And I believe that what we're finding here is actually that the label for the general public in each of these studies, these are people who themselves do not have BPD, the label actually provides a context for understanding behavior. It's a small educational tool. It's an educational nudge to say, hey, there's a reason why this person might be acting in this way. Right? There's a reason this person might be struggling in this way, and it's this diagnostic label. So in both these cases, you can see that the purple bars, right, that's the no label condition. That's where we saw the greatest stigma across 2 studies. The first study also had a condition with schizophrenia that you see depicted there. We saw a slightly similar effect actually for schizophrenia. And then on the right, we actually broke it into female and male vignettes. So it was Anna versus John. But in both cases, the primary finding holds. And these are just examples of anger towards Anna and blame towards Anna. There are other aspects of stigma that we measured as well. So to express this in a different way, we had more blame and anger expressed towards BPD when the behavior was unlabeled. We also saw, interestingly, more blame and anger expressed towards BPD relative to schizophrenia. Labels did not differentially affect stigma for BPD versus schizophrenia in study 1. And we also didn't find really significant impacts of gender in terms of blame and anger. There were some effects for other aspects of stigma not reported here that I'm happy to talk about with you if you have questions about that. So again, I believe that labels might provide an explanation or context for behavior that mitigates blame, anger, and other aspects of stigma, at least for the general public. I'm going to turn gears here because I think oftentimes it's important to think about public stigma in terms of the general public, but we also need to be thinking about stigma in clinical spaces and specifically clinician stigma. We know from a wealth of research, and many of us know from our own experiences, that clinicians often have very negative, stigmatizing views of BPD. I won't enumerate or specify the negative attitudes here, as I'm sure that folks in the audience are well aware of them. They're clear in clinical spaces and in the research literature. Importantly, they often occur in tandem with clinicians reporting lower willingness to treat people with BPD, meaning that they may influence treatment access and outcomes. Fortunately, what we know from another semi-wealth of research is that there's a number of papers showing that we can actually improve these negative attitudes through training, through education. One thing that I'll point out here that will become relevant later is that all of these papers shown here examines training in a postgraduate professional context. So each of these studies used education or training programs after people had completed their degrees, whether that's a master's degree, whether it's a doctoral degree, whether it's a medical degree. And they use these educational training programs to reduce stigmatizing attitudes in these people who were already practicing in their respective fields. And in each of these cases, short educational programs seem to improve clinicians' understanding of BPD and decrease their stigma. And I'll give you one specific example of this. So Kroglian and colleagues polled almost 300 clinicians, and they did this before and after a one-day training in good psychiatric management. If you're familiar with good psychiatric management, you might know that a key piece of good psychiatric management is psychoeducation. So a big part of this training is actually just helping clinicians understand BPD so that they can provide psychoeducation to their patients. There were also aspects of this training that had to do with the specific principles of GPM beyond that. And what they found after training, that should be an arrow that says decrease, was that clinicians expressed less likeliness to avoid people with BPD. They expressed less dislike, and they also expressed less hopelessness in helping people with BPD. On the other hand, what increased was feelings of competence. People felt that they had the tools ready to help people with BPD. They also increased their belief that people with BPD have low self-esteem and that this was something they could help them with. They had an increase in their ability to have a positive impact, their belief that they could do that, and in the belief that therapy is useful. Now, that's all well and fine, but you might actually ask, given what we know about education interventions from the general stigma literature, how does this translate or endure over a longer time period? And so we looked at that. We surveyed 120 mental health workers, and we had some attrition, so difficulties with retention. 52 of them followed through to complete surveys at 6 months. These were psychiatrists, social workers, psychologists, and others. And their average experience was 18 years. So these were people who had been practicing for a significant chunk of time. What we found is that at 6-month follow-up, attitude changes in 12 out of 19 characteristics that we measured showed lasting change. So this wasn't just that at the end of the training, they felt a little boost of hope. This was something that endured at least out to 6 months. And so again, we saw decreases in that wish to avoid, in dislike, in hopelessness, also in the belief that people with BPD have low empathy, that belief decreased, and also decreases in discomfort treating people with BPD. We saw increases in feelings of competence at 6 months, the belief that BPD is a distressing disorder, the willingness to make the diagnosis, and the belief that therapy is useful. So when clinicians have training about BPD, they have more positive attitudes about BPD. They feel more competent and prepared, and they're more likely to provide appropriate care. John Gunderson used to sometimes present a slide that said something like, people with BPD have the right to expect that their clinicians know how to help them, full stop. And I believe that wholeheartedly. We need to examine, however, how this training translates to behavior change. It's not enough just to know that attitudes change. We actually want to see that clinicians are taking on more people with BPD into their caseloads. They're not sending those referrals out. That the care they're providing is effective, is empathetic, is compassionate. And we also need to start to consider how disseminating training to clinicians in training programs might be important. It's all well and fine to start training people who are already practicing. That's really important. It is a key part of destigmatizing efforts. But in that study, people have been practicing for 18 years. That's a lot of time to have negative views already entrenched. And we know that stigma interventions in the education arena are most impactful when people's views are most malleable. So we should be training them directly in their graduate programs. So this is where I've started to look recently. So what education and clinical training are doctoral students getting? This is going to have implications for clinical work and also for research practices related to that recent paper. These questions, I'll note, are also quite important for master's level clinicians and MDs and nurses and other professionals who help people with BPD. This is just a starting place. I started with PhD and PsyD programs because these are the programs I'm most familiar with, and because the list of them is much shorter than the list of master's programs. So honestly, there was also a pragmatic piece here as well. And what we did in my lab is my undergraduates helped me identify all of the APA and PCSAS accredited PhD and PsyD programs in clinical and counseling psychology in the United States. So these two accreditation bodies, if you're not familiar with this, the APA, the American Psychological Association, accredits programs, doctoral programs, based on certain curricular offerings that they need to have, based on certain outcomes that they also need to have. PCSAS is another accreditation body that's newer than APA, and it actually arose following concerns about APA accreditation and how it does or does not value research as part of the doctoral training experience. So there's fewer programs that have this PCSAS accreditation. But we identified all 345 programs, and I emailed the DCT of every single one of these programs directly and twice now. I am continuing to follow up with them. And we asked them a few things. We wanted to assess a few things, and I would have liked to assess more, but it's really hard to get them to respond. So we had to keep this brief, at least for this first look. So we looked at whether they required or offered coursework on BPD or personality disorders, whether they offered training and assessment. So structured assessments include things like the SCID or the DIPD or the DIB. These are assessments that are specifically designed to provide a reliable diagnosis of BPD. We also looked at unstructured training and unstructured assessments, things that take a more dimensional approach, like the MMPI, the PAI, the SNAP, and other measures like that. We looked at whether they required or offered clinical training with BPD or a personality disorder focus more broadly. And we asked them to estimate the percentage of their trainees who graduated with some training in BPD or personality disorders. Finally, we asked them about the presence of program faculty who had an expertise in personality disorders. And at this point, our response rate is almost 28%. I would love to get this to 50%. I'll probably settle with 30 or 40%, but I am still wrangling these data. So 82 of these programs were APA accredited. 14 had both APA and PCSAS accreditation. The majority were PhD programs with some PsyD. One program actually offered both degrees. And the majority were also clinical programs. 17 were counseling and 4 were combined. So those are programs that are clinical counseling or clinical and school psychology. And first we can look at coursework. So what I'll point out to you here is that I promise you, I had the key here. But what you see here, the 45%, the green, these are folks who do not offer coursework on BPD or PDs. 45% do not offer coursework on borderline personality disorder or personality disorders more broadly. We're not even talking about requirement. We're talking about whether they offer the course. Those that answered other in the 36%, this is a little bit more hopeful in that these are folks who said that they have a course on general psychopathology that at least has some coverage of BPD. Okay, that's okay. Some disorders get covered in that way in a general course. Next, we can look at structured assessment. And what you see here is that the 58% here do not offer training in structured assessment in BPD. That means that they do not offer their graduates a way to make the diagnosis in a reliable way. 58%. 29% require this training. The 10% is other. And again, this is assessments like the SCID, the DIPD, or the DIB. Surprisingly, programs are doing a little bit better in this area. So this is unstructured assessment training. They usually noted that this is part of a general assessment course, but these 78% of these programs reported that they do offer, or they do actually require training in things like the MMPI, the MCMI, the SNAP, PAI, these dimensional measures of personality traits. And I think that's fantastic, but I think there's also something problematic in that these programs are probably also offering structured assessment training in what used to be called the Axis 1 disorders. So you can imagine a graduate who's learning to give the SCID for major depressive disorder, but then the only assessment training they're getting for BPD is the PAI. And that's going to entrench this idea that you don't make the diagnosis. You assess personality as a background condition, much like we did when it was relegated to Axis 2 in the DSM. This is clinical training, okay? Fortunately, more than 50% of programs, the 55%, offer clinical training in BPD or PD. So this is offered, but not necessarily required. And this is either in their in-house clinic or through external practicum sites. Still, 42% do not offer this training at all. 42% do not offer training in personality disorders, not offered. I cannot imagine standing here telling you that 42% of doctoral programs in the United States, if we consider this representative, we're still getting more data, don't offer clinical training in mood or anxiety disorders. That would be bonkers. So is this. I also wanted to examine the presence of program faculty who have personality disorder specialties, assuming that they may serve as role models or at least increase the focus on personality disorders in less tangible ways. The majority of programs do not have these faculty. So 61% of programs reported that they don't have a faculty member who specializes in personality disorders in a clinical or in a research way. A small percent have faculty who specialize in research, that's the 8%. And the 7% is faculty who specialize in clinical work or practice with folks with BPD or personality disorders. So overall, also there's a quarter of folks who do both. Now, this is an interesting one. I'm going to actually ask for some participation here. Of the 96 programs, 85 indicated the percent of their students who received clinical training in personality disorders. I'm going to ask you to guess this number But first, I want to remind you that in clinical spaces, the prevalence of BPD is as high as 25 to 30%. This means that 1 out of every 3 or 4 patients in many clinical care settings has BPD. So first, I want to ask you, what percent of PhD and PsyD trainees do you think should have this training in BPD or PDs? I heard 100%. 100%. 100%, right? Anyone want to wager a guess at what percent you think do across these 85 programs? 12? 7, 12, 8, 3. Okay. You're all low, which is actually really good. So they're outperforming, okay? 29, just over 29%. So these 85 programs are saying that just over 29% of their graduates graduate with experiences related to BPD or personality disorders. Correct. Mind you, this doesn't include predoctoral internship. So I'm saying graduating, but I'm using that a little bit loosely. They might get this experience through their predoctoral internship, sorry. The range was quite broad, from 0% to 100%. And that was a program that has a DBT specialty. PhD programs were slightly higher than PsyD programs, about 7%. That didn't reach statistical significance just yet, but I still think 7% is something. Some other findings here. Several programs indicated that APA requirements actually limit their ability to offer courses in this area. They reported to me that they have so many courses they have to offer to meet APA accreditation guidelines that they're just constrained and they can't offer the coursework that they would like to in this area. There were also some concerning comments. So for example, I got some statements about how BPD is irrelevant because their program focuses on children or adolescents. I also got an assertion that BPD is overdiagnosed and is really underlying PTSD. That person must believe that very strongly to admit that to me in an email when I'm clearly asking questions about these programs and coming from a perspective supporting folks with BPD. There were some hopeful comments. So for example, there was a desire to increase offerings, as I mentioned. There was a recognition that personality disorders are present in all clinical placements. There's also one program reported using the alternative model of personality disorder for all in-house clinic assessments, which is really great. That means that at least one program is kind of leading the charge to use new cutting-edge models and measures of personality disorder in all of their assessments. I just hope that we can follow that direction. There's some limitations here. So these data cannot speak to the content of training. Even if 100% of these programs were offering this training, these data can't necessarily say whether that training is adequate, right? If it's actually presenting information in a way that is useful, or if it's perpetuating stigma. And also the response rate, as I mentioned, we're still collecting the data. Nevertheless, I think this reveals that there are significant training gaps for PhD and PsyD students, particularly in structured assessment and coursework. Most programs offer training in that unstructured personality assessment. And again, I'll say that's great, but that also has some limitations. Most programs do not include faculty with personality disorders expertise, and more than half of programs do not offer clinical training in BPD or personality disorders. And I'm conducting this survey as really a first look at what needs to change. And I'm actually looking for partners in starting to change this. So I've been talking to folks about how we can actually start to use some advocacy work to get more training into these programs so that we're not reaching people after they've already graduated, so that we're reaching them earlier when their beliefs might be more malleable. And there's some exciting avenues that we're starting to explore there that I'd love to talk with you all about afterwards. And of course, less than 30% of graduates are getting this training. And I would argue that this leads to a really big pipeline issue. So a former student of mine, Evan, and colleagues examined the supply of mental health professionals with training in specialized treatments, things like DBT, for BPD across BPD in 22 countries. And they looked at the ratio of treatment-seeking people with BPD to mental health professionals with this specialized training. And what they found is startling. 50 to 1 in Norway, nearly 150,000 to 1 in Mexico, nearly 6,000 to 1 in the US. This means that for every 6,000 people with BPD who are seeking treatment, never mind those who are not seeking treatment, but for every 6,000 who are seeking treatment in the US, there's one clinician with specialized training. And I would argue that this is in part because doctoral programs, and I suspect master's programs as well, we'll look at that, are not providing the training that gets people started. There's other reasons for this as well, right? So these specialized trainings are hard to get trained in, right? They're expensive, it's time consuming. But we need to get education earlier in the pipeline to start to address some of these issues. I would argue that this access issue is itself also the product of and a key maintainer of stigmatizing views of BPD. So bear with me again. I'm going to switch gears to psychoeducation and self-stigma briefly before I weave together that thread that I have promised. So first, a general framework from the literature on stigma. So public stigma occurs across different spheres. So we've looked today at clinician stigma. We've also considered the public stigma that kind of the general public might have about BPD or other mental illnesses. Public stigma can, apologies for the graphics, can actually become entrenched as self-stigma when there's 3 key elements in place. The first is that a person needs to be aware of the public stigma. They need to know that it exists. Then they start to agree with the public stigma, so believing it to be true. And then they start to apply that stigma to themselves, and actually it translates into behavioral change. So public stigma, when it has these 3 A's, awareness, agreement, and application, starts to become entrenched as self-stigma. And we know that people with BPD experience more self-stigma than people with other diagnoses, for example, anxiety disorders. And this is likely because of the identity concerns and the sense of shame and negative self-concept that we often see in BPD. So self-stigma is going to be particularly potent, likely, for people with BPD, resulting from this awareness and internalization of public stigma. Self-stigma is associated with suicidality, so it is deserving of research and clinical attention in and of itself. And I like this quote from Patrick Corrigan. He wrote that one of the most significant harms resulting from self-stigma is the foreclosure of important life pursuits by individuals who come to believe they should not pursue goals that society thinks such individuals cannot achieve. So when people internalize self-stigma, they might stop striving for educational goals. They might stop striving for the relationships that they want, for the self-fulfillment that they would like to see, because they start to believe that these are things that are not achievable for them due to the self-stigma. So self-stigma is something we need to directly target. And in the research landscape, we know that we can change self-stigma. So most studies that target self-stigma show improvement. Psychoeducation, education, is the most common component of successful interventions for self-stigma. So interventions either seek to change stigma directly by altering the beliefs and attitudes, or interventions can help people cope with stigma without changing it. So enhancing coping through things like empowerment and group affiliation. I would argue that this conference does both of these things really beautifully. Problems with the research literature here is that there's been a near exclusive focus on schizophrenia. There's also some methodological issues. So many of these studies don't include control groups, for example, or have a lack of randomization. And the other limitation, I would argue, another limitation is that not many studies have actually looked at how to change self-stigma specifically in the context of BPD. However, we do have a good amount of indirect evidence that educational programming likely changes self-stigma. So first off, these are not studies I conducted, but these are examples. In a 12-week psychoeducation workshop, researchers saw decreases in impulsivity and unstable relations and concluded that this was a useful and cost-efficient form of pretreatment. In another brief psychoeducation group, there were decreases in affective, cognitive, and interpersonal symptoms sustained at 2 months for people with BPD. 46% in the treatment group here fully responded, and that was defined as a 50% or more reduction in the ZAN BPD score for those folks. And there's other evidence that in many cases, the reaction to the BPD diagnosis can be seen as a turning point in helping patients conceptualize experiences. The diagnosis can often bring validation and relief, I think, as we've seen in the beautiful stories that we've heard from first-person accounts today. And the majority of people do report acceptance of, or at least interest in, the BPD diagnosis. And I would argue that the mechanism through which these psychoeducation programs are impacting these symptom changes is probably, in part, that they're reducing self-stigma, but we haven't been measuring this. And I think this is a key direction where we need to actually start to directly measure self-stigma and related processes, things like shame, directly. So in summary, I'm going to weave that thread and look ahead. Mental illness education that recognizes stigma does not appear to have a rebound or ironic impact. That's good news. We can talk about the stigma in the service of dispelling it. The BPD diagnostic label, in some cases at least, may impart knowledge or understanding that attenuates stigma, at least for people with little previous knowledge of BPD. I fully recognize, right, that the label comes with increased stigma in some spheres. This is just one data point as we think about how to use labels and in what context. Clinicians who should have knowledge of BPD, but often don't, often stigmatize. But training helps. Training focused on BPD and PhD and PsyD programs is minimal, which may make stigma likely. And people with BPD also hold self-stigma, which may be alleviated in part with psychoeducation. So what we have, and my graphic I'm predicting is not going to show up perfectly well, but we have public and clinician stigma. I'm going to put at the center of this model, leads to self-stigma, reminder of those 3 A's of awareness, agreement, and application. I would argue also that aspects of BPD are also going to contribute to making self-stigma worse. Things like shame, things like identity concerns, sense of low self-concept. Educational efforts, however, can have an important role. So myths versus facts, we can actually dispel stigma by talking about it and providing the accurate information to decrease public and clinician stigma, which I would hope would have the downstream effect of decreasing self-stigma. We also know that in some cases, at least in some contexts, providing a diagnostic label may also be an important educational tool, a little educational nudge. Clinician workshops are also really important in this regard. But what we really need to do is start to tackle this lack of training in doctoral programs so that we're disseminating this knowledge more broadly and at an earlier stage in the educational scheme. Psychoeducation can also have a direct impact on self-stigma. So there's just many ways where education plays a role here. So looking ahead, we need to join education with advocacy to push for changes in training and to further assess knowledge sources. So as I said, I'll look at master's programs and also medical training programs, and even undergraduate education may play a role here. Psychoeducation programs for BPD should assess self-stigma directly. And I'll end with this. I love this quote in Latin, and I probably cannot pronounce it despite having taken 4 years of Latin in high school. I don't know why I did that. But nihil de nobis sine nobis, right? Nothing about me without me. The majority of the research that I showed you from my lab, at least in this slide deck, included people on the research team with lived experience of BPD. And I really value conferences like this one because we need people with BPD to be part of this process to help us understand what psychoeducation and other educational programs should look like. We should not be proceeding in this work without those voices. And I thank all of you who have had the courage to speak today, and those of you who are also participating in helping researchers and clinicians in their efforts as well. And some thank yous, NEABPD and conference organizers, participants, my research assistants, past and present. There's Thea, thank you. And folks who continue to think about these issues with me, including the GPM Research Committee and others, mentors, teachers, and friends who have instilled knowledge and compassion, and organizations that continue to inspire my work. And I thank you all for your attention.
All right. Well, thank you, Dr. Masland, for educating us on education. We have a bunch of questions that came in, so we'll do what we can. So you ready?
Yes.
All right. Has any of it explored differences in stigma when we compare labels of borderline personality disorder compared to PTSD or CPTSD, complex PTSD?
That is a really fantastic question. The short answer is no, I haven't done that. And I should, right? I think we do need to be looking at all the ways that BPD sometimes gets labeled in different ways for various reasons.
Any research you can tell us about that decreases stigma through education in healthcare workers outside of mental health? So healthcare workers that aren't in our field of mental health.
Yeah, there are some efforts. I believe Victor Hong has done some of this work in the Midwest, looking at emergency room providers. We know oftentimes at the point of contact for folks with BPD in hospital systems is through the emergency room at times of crisis. And it's really key that we have educational programming for those workers so that they know actually how to react in that situation. And that work shows that I think that it's effective, but it's one of these things that we do need to disseminate more broadly.
And on that note, NEAPPD has a program. People here probably know about Family Connections for family members. There's a program outside of the US in the country of Ireland called Clinician Connections that gets at this topic. People are interested. All right, Dr. Masland, does the efficacy of training differ as a function of any cultural or demographic factor? So the participants in your studies, where they are in the country, race, SES?
That's an incredibly important question. We need to be looking at intersectional identities here. And I don't have the data because unfortunately these studies are predominantly white folks. The GPM training study that I showed you with the 6 effects out to 6 months, that was done at Maine Medical Center. Maine is the whitest state in the country. Fortunately, it was looking at folks who provide services in rural health settings, which are often neglected, but certainly wasn't able to look at any of these important demographics.
Another on this theme, what about differences from providers across fields, therapists, mental health workers versus psychiatrists linked to bias and stigma?
The work here is inconsistent. Sometimes we actually see some data are actually showing that the stigma is greater in, social workers versus psychiatrists. Some show the opposite. The qualitative work also similarly shows that the stigma is probably pretty widespread. It may have different maintainers. However, it might have different causes, and we might need different types of interventions for different types of providers. But I do think that it is something that all providers need to be thinking about. So if trainees like doctoral students want clinical training in PDs, specifically BPD, but their program doesn't include it, what can they do to obtain this training? That's a great question. I would say do whatever you can to find external practicum sites in your area that do offer that training. So for example, if you're, if you have the good fortune to be in Boston, there's lots of external practicum sites, for example, that offer training in BPD. I imagine there's many here as well. I went to graduate school in Boston, so that's why I'm thinking about it. But forge your own path, right? When I went through my graduate program, I was the first person to do an external practicum site at the Gunderson residence at McLean. And now graduate students do that regularly. So go out there and do it.
Okay, so question about GPM, so good psychiatric management. As GPM reduces stigma, is there a study looking at the prevalence and accessibility of GPM at the institutional or clinical level?
Is there one study that looks at this? No, but one of the primary goals of GPM is to be a more accessible treatment. It requires much less training. It's meant to be a generalist treatment that clinicians who are trained in other techniques can learn pretty quickly. When GPM was first developed, the trainings were offered for free, and they've been offered actually all around the world: Dominican Republic, Italy, Switzerland, Brazil, not all continents, but certainly a good number of places. The trainings have been offered, and I think that there's still a lot of efforts where we're trying to get that disseminated and more accessible. There's online training that's available for low cost, but we don't necessarily have a good systematic study that's up to date on the number of people trained in GPM, but we're working on it.
So relatedly, someone asked about a publication or some other resource, education, to help people understand what GPN is and potential to get more qualified clinicians to treat borderline.
Yeah. A recommendation for what GPM is. I hate to toot my own horn, but it comes up right away. I wrote a review paper in 2018 that you could look up. Very short review paper on what GPM is. Wrote that with John Gunderson and Lois Choi Kane. Those are the people to look at if you're wanting to understand GPM, for sure.
Do you think there are changes over time that will affect how willing people are to train students about BPD? For example, as new directors of clinical training take over? Or do you see this as a more lasting problem?
More lasting problem.
More lasting problem. So are there changes that will influence this, and what are the changes that you envision?
Yeah, there's actually some data to suggest that the stigma that clinicians hold about BPD has improved over time. So we do know that there are improvements. I would like to just see them catalyzed and happening faster. But I do think as we start to see turnover in these programs, in the context of all of this talk of stigma, right? This conversation is new. And as this conversation starts to reach more people, I think that we will see kind of escalating improvements across programs.
Okay. So given that the APA requires clinicians to practice within their competency, should programs prioritize faculty with expertise in these areas to increase the number of trainings that can do this work?
Yes, yeah, absolutely. Like I said, 25 to 30% of folks in many clinical settings have BPD. I think that we need to make sure that people have the ability to help them.
How concerning is it that a book you cited in your paper, The Siren's Dance, was written by a BPD psychiatrist under a pen name?
Really concerning. If that's your question, I'd love to talk more with you about that.
And someone asked, may I know the PhD or PsyD programs that have a focus on BPD or PD, please? And thanks.
Oh, the list of programs that have the focus. I don't know off the top of my head. I think the 100% was probably the University of Washington because they have the DPT program. But I'm not supposed to really identify the programs, but I can certainly help guide you towards the better ones if you want to ask me afterwards.
So I was going to ask, how much do you think, I know you didn't show these data, but the programs that endorsed BPD training, how much of that is a function of those programs offering DBT training?
Yeah, it is very often DBT training. Yeah, so they have a DBT rotation either in their in-house clinic or externally, or they have a faculty member who's, very much in the DBT camp. And I do think that we need to see representation of other treatments in these training programs. And actually, I've started to talk with Lois Choi Kane at McLean about ways that we can actually use short trainings in GPM and get those implemented into clinical training programs so that everyone at least has a generalist model of care presented to them when they leave their doctoral training.
So one of the barriers to accessing treatment for BPD when it's DBT is getting a therapist who's trained with this intense training and insurance coverage. Could you say anything about how accessible it is to find GPM, and does insurance tend to cover that treatment as an in-network treatment option?
So as I said, one of the goals of GPM is to make sure that we're making it more accessible, but there are still challenges in that area. Absolutely. I think it varies by state. It also varies by insurance provider, as it does with any other treatment. But we are seeing improvements, and you can get GPM covered by many insurance providers.
Last question.
Sure.
If you could think about younger version of yourself as an undergrad who did not learn a thing about personality disorders or BPD in undergrad, what would you want to tell yourself?
Well, I'm naturally like a really kind of skeptical person. So I almost would say like I would tell myself to be skeptical, but I already was. I think that's why maybe it had less of an impact. I would tell myself to get connected to one of these organizations sooner, right? NEABPD, Emotions Matter, Terra4 BPD, NASPD, ESSPD, all of these organizations have a common thread in that they involve people with lived experience. And I would tell myself as an undergraduate that before I took any information as a solid gold brick, like any education, that I talk to someone who has the experience of the thing I'm learning about, that I don't let the education be confined to the classroom.